Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary, and our team is here to explain lipid disorders. Endocrinology as a study involving hormones is in its nature a systemic one. There are multiple pathways and enzymes that are required to process and redirect lipid components of the food, and the organs affected by this process, it includes the eyes. The disorders in general in endocrinology that leads to high levels of triglycerides or cholesterol can also lead to damage in the eye as well. Lipid disorders can be largely categorized into hypertriglyceridemia, hypercholesterolemia, or a combination of both disorders. To better understand how lipid disorders can have an effect on the eye, let's cover the anatomy of the relevant structures, retina and the cornea. Retina is a light-perceiving layer deep within the eye and is composed of several layers of photoreceptors and ganglion cells to perceive and properly translate the photon signals into electrical signals. When viewing a patient's fundus, you should also be able to notice the fovea and the macula, which is the site for central vision. And on the opposite nasal side, there is the optic disc, or the blind spot, where all the ganglion cells come together via their axons and exit as optic nerve. The cornea is also composed of 5 main layers: the epithelium, Bowman's layer, stroma, descendant membrane, and the endothelium. This part of the eye provides the highest refractive power of the incoming light, much more than the lens. Here is a comprehensive a view of the lipid processing by the body, and a rather poor drawing that I have attempted. So starting from the left, when the food passes through the GI tract, the pancreatic lipase breaks the fat down into free fatty acids and glycerides. The lipids are mixed into emulsification droplets with the bile salts, and this clump is absorbed by the epithelial cells in the small intestine through the NPC1L1 receptor. After entering the cell, these units of lipids form triglycerides again and is formed into a chylomicron. This chylomicron then exits the cell and enters the lacteal, which is then circulated into the lymph system. Chylomicrons have a high content of triglycerides and low cholesterol, and with the lipoprotein lipase, it is converted into chylomicron remnants, which has low triglycerides and high cholesterol. This chylomicron remnant is absorbed via the LDL receptor with the help of LRP1 in the liver. The remnant is processed into very low density lipoprotein, which has high triglycerides and low cholesterol, and is converted into IDL, intermediate density lipoprotein, or VLDL remnant by the lipoprotein lipase in the liver. 50% of this version of the remnant goes back into the liver via the LDL receptor to be directed for excretion and other processing. And the other 50% is converted into LDL by the hepatic lipase. The LDL is circulated throughout the body and encounters LDL receptors by the somatic cells. Upon absorption of the LDL, this can be used for fuel and formation of cell membranes. Some risk factors of lipid disorders include lifestyle, keeping a fatty diet overall, and drinking lots of alcohol makes individuals more vulnerable to lipid disorders. Diabetes and obesity can raise this risk as well. Hypothyroidism and chronic kidney disease developing into uremia are specific medical conditions that are dangerous for lipid disorders. Certain drugs like steroids, estrogen and thiazides, and beta blockers are also relevant in this case, and Cushing's syndrome is something we need to touch on as well. For hypertriglyceridemia, you might notice on the patient the lipemia retinalis in the retina upon a fundus exam. Eruptive xanthomas are yellow eruptions on extensor surfaces, so on the backside of the joint, not the side that folds, but the side that extends. And hepatosplenomegaly can be noted as well. For hypercholesterolemia, xanthelasma are the eruptions around the orbital region, as noted by the top left picture there. Tuberous xanthomas are shiny red or orange nodules, and you may also notice a thin ring around the cornea as well. Atherosclerosis and aortic sclerosis is another important sign of lipid disorders, and this predisposes the individual to a lot of high risk for various ischemic heart diseases or vessel diseases. And tendon xanthomas can also erupt on lots of tendon areas with familial hypercholesterolemia. Complications of lipid disorders include chylomicronemia syndrome, which is a very severely increased triglycerides causing the following symptoms. So pancreatitis, memory impairment, shortness of breath, confusion, and abdominal pain. When observing the serum and centrifuging it down to different components, you may also notice that the plasma portion appears very milky. With lipid disorders, there may be many different causes and therefore a lot of differentials, including the LPL deficiency, which is the lipoprotein lipase we talked about, apolipoprotein C2 deficiency, which is a coenzyme for receptor processing, familial hypertriglyceridemia or hypercholesterolemia are also possible, polygenic hypercholesterolemia, familial combined hyperlipidemia, which includes both of the triglycerides and cholesterol increase, and familial dysbeta lipoproteinemia is also a possibility. Do a complete ophthalmic history, whether there has been visual disturbances. Do a slit-lamp exam and focusing on the cornea and the retina through a fundus exam. Cover all their medical conditions and their progression. And also ask of any family history of ophthalmic conditions and or lipid disorders. For investigating lipid disorders, ordering CBC and doing a thorough lipid panel including cholesterol, triglycerides, HDL and LDL, and also the total to HDL cholesterol ratio would be desirable. Treatment of lipid disorders includes a goal of reducing 50% the LDL or reducing it to less than 2 millimoles per liter, and we can use statins for that. This would be the gold standard of therapy, and bile acid sequestrants can be an add-on if the statin isn't doing as good of a job. Ezetimibe can also lower the LDL, but it can also cause myalgia and diarrhea as well. PCSK9 is a costly new drug developed for lipid lowering, and this is great for high-risk cardiovascular disease. A goal in the case of hypertriglyceridemia is to lower it to below 4.5 millimoles per liter, could give fibrates, icosapent ethyl. And because triglyceride levels are dependent on diet much more than genetics, because changing the diet would affect this and have a much more positive outcome on the patient. So here is a summary slide of everything we have talked about. Here is the reference from which we pulled the information. And here are the references for the images that we used throughout this presentation. Thank you for watching this video.